effects of metformin. I will also explain the pathway that is responsible for the formation of lactate in the liver and also mention some of the precautions and contraindications that needs to be kept in mind while prescribing metformin. So starting with the side effects of metformin. Nearly 20% of the diabetic patients that are prescribed metformin experience gastrointestinal side effects such as nausea, vomiting, diarrhea, gas, abdominal bloating and decrease in appetite. So metformin commonly causes gastrointestinal side effects. Metformin can also cause vitamin B12 deficiency. So vitamin B12 deficiency occurs due to inhibition of intestinal absorption of vitamin B12 by metformin. So this decreases the serum B12 concentration, causing deficiency. In rare patients, vitamin B12 deficiency can lead to peripheral neuropathy and megaloblastic anemia. So taking a daily multivitamin protects against vitamin B12 deficiency. One of the serious side effects of metformin is lactic acidosis. So let's understand the pathway that is responsible for lactate formation in the liver. So metformin when taken orally is absorbed into the hepatocyte from the portal circulation through transporters that are expressed in the hepatocyte membrane. So organic cation transporters allows metformin into the hepatocyte. Once it is inside the liver cell, it inhibits the electron transport chain and this decreases the ATP and increases the cyclic AMP concentration. With the rise in cyclic AMP concentration, the AMP protein kinase enzyme gets activated. And kinase enzyme is responsible for phosphorylation, and phosphorylation of gluconeogenic genes causes inhibition of gluconeogenesis, a process that is responsible for the production of glucose. So metformin by inhibiting AMP protein kinase enzyme causes inhibition of gluconeogenesis, thereby decreasing the hepatic glucose production. So this is the primary anti-diabetic action of metformin. But the downside of metformin is that with the inhibition of electron transport chain, it also inhibits the mitochondrial glycerol 3-phosphate dehydrogenase enzyme. Now this enzyme is responsible or it catalyzes the conversion of glycerol 3-phosphate to dihydroxyacetone phosphate. Dihydroxyacetone phosphate plays a major role in reoxidizing NADH that is produced during glycolysis to NAD. So NADH is converted to NAD in presence of glycerol 3-phosphate dehydrogenase enzyme. So when glycerol 3-phosphate dehydrogenase enzyme is inhibited, so inhibition of this enzyme decreases the formation of dihydroxyacetone phosphate and this also reduces the conversion of NADH to NAD. So NADH fails to provide electrons, fails to transfer electrons to NAD and this increases the concentration of NADH in the cytosol. With an increase in NADH concentration in the cytosol, pyruvate gets converted to lactate in the liver. So this causes lactate formation in the liver because of excessive NADH concentration in the cytosol. So this is how metformin exerts its anti-diabetic action but also at the same time increases the formation of lactate in the liver. Now do remember that in aerobic conditions when the oxygen supply is adequate, pyruvate enters the mitochondrial membrane and continues its oxidative path and is utilized in metabolism and NADH remains in the cytosol. But in anaerobic conditions when there is deficit in tissue oxygen, pyruvate gets converted to lactate in presence of lactate dehydrogenase enzyme. So in anoxic conditions such as cardiopulmonary diseases, for example congestive heart failure, when the heart fails to pump oxygenated blood to the tissues, decreasing the tissue oxygen availability. In pulmonary diseases such as pulmonary fibrosis, pulmonary edema, there is decreased oxygen supply in the lungs, and also in severe infection or sepsis, the tissue oxygen deficit increases and this increases the conversion of pyruvate to lactate, leading to dangerous accumulation of lactate in the liver and predisposing to lactic acidosis. Also, in organ dysfunction such as kidney disease and liver disease, metformin should be administered with caution. Metformin should be avoided when the GFR is less than 30 ml per minute and the creatinine levels are higher than 1.5 milligram per deciliter. This is because metformin is primarily eliminated by the kidney, and so in kidney impairment there is accumulation of metformin and this causes dose related toxicity. Also in liver disease, the glucose metabolism is disrupted and this increases the formation of lactate in the liver, increasing the risk for lactic acidosis. Next, certain conditions may also induce metabolic acidosis. For example, diabetic ketoacidosis, uremia, or alcohol abuse, because excessive alcohol is converted to aldehyde, which in turn gets converted to acetic acid in the liver. And this can induce or increase metabolic acidosis and increases the risk for lactic acidosis. So to sum up the key points, the commonest side effect of metformin is gastrointestinal side effect. The serious side effect of metformin is lactic acidosis. The pathway for lactic acid formation has been described in detail, and also I have explained some of the precautions and contraindications that needs to be kept in mind while prescribing metformin in type 2 diabetic patients. So thank you for watching. If you find this video useful, please like and subscribe to this channel.